first 5 minutes will be to Mr. Patzer.
Thank you very much to both witnesses. I really appreciated your testimony, and I'm just going to start with Dr. Chochinov there. If you could just elaborate a little bit more, because you have a tremendous experience. I think you said 35 years studying human suffering and developing interventions specifically targeting the desire to die. So I'm just wondering, though, for a patient whose suffering feels irremediable and who has lost all sense of dignity and purpose, what does the evidence say can actually be offered, and what results have you seen in your 35 years of experience? You're on mute.
It's a wonderful question. I mean, I'll confine my responses to the work that I've contributed, although there are colleagues worldwide who are working in this area, trying to understand human suffering, the whole field of psycho-oncology, trying to figure out how can we attend to the psychological underpinnings of a critical illness. We have developed something called dignity therapy, which is a way of helping patients to kind of reclaim their narrative thread, to be able to tell their story, preserve their legacy. Originally, this was designed in palliative care. It is also being used in patients with mental illness. There was recently a randomized controlled trial of dignity therapy in patients with major depression. And the results were that by giving people this opportunity, it actually increased their level of hope. I've also been developing something that I refer to as intensive caring. This was published in the Journal of Clinical Oncology. The framework is now being published in multiple languages and being disseminated worldwide. And essentially, it's a paradigm shift and describes a paradigm shift for healthcare providers. I mean, in life and in medicine, we're often faced with things that really aren't fixable, but that doesn't mean that we don't have a role to play, to be attentive. So intensive caring describes some basic stances that healthcare providers can take with their patients to engage them in a way in which they can feel less helpless and the patient can feel appreciated. For example, just showing up, committing to non-abandonment, being present, being attentive. And again, it's hard to summarize 35 years worth of work briefly, but when I wrote an article objecting to MAID a couple of years ago, a young man wrote me back who was very angry with me. He was experiencing severe mental illness, and basically what he was trying to say is, Chochinov, piss off. This is my decision. This is something I want. I'm suffering, and who are you to get in the way? So I wrote back, thinking again about this idea that we need to be respectful and engage in relationships and be kind and validate his experience. And I said, listen, thank you for reminding me of the anguish of critical mental illness. And at the end of the correspondence, and I just about fell off my chair, I mean, almost immediately, he wrote me back and he said, thank you. Even corresponding with you, you have given me hope. Maybe not that my illness will get better, but there are doctors out there who actually care. So when Dr. Gagnon was talking about relationship, connectedness, there's good evidence, even in oncology, that the degree of connectedness between the patient and the care provider is the most ardent predictor of suicidality. So this idea that we have nothing to do for somebody, we need to commit to saying we do have something to do with them. We may not be able to fix them, but we are committed to showing up. And when we show up, we know that we can offer comfort that can change their experience.
Yeah, I think you hit the nail. Yeah, you hit the nail right on the head. And I think when we look at especially when we look at the numbers in Canada, I mean, we're around or maybe even over 100,000 people that have already ended their life with MAID. And you talked about some of the other numbers, looking at the Dutch model there. I'm just wondering, do you have any other concerns with what we're seeing in statistics around the world that might give us some forewarning if we were to proceed down the path of Track 2 expansion?
Very briefly, Dr. Chochinov.
Well, again, I mean, I think, I like to follow the evidence. Scott Kim has extrapolated the number of people that we can expect based on the number of requests that we're seeing in Holland. We're talking, even though some people said this is a very tiny number, we're talking about 2,500 to 5,000 Canadians with severe mental each year who are going to line up, about half of whom, are going to actually then receive MAID. So I have grave concerns, which is also, and that's setting aside the fact that there's the collateral damage.
Thank you very much. Next, we'll go to Ms. Jacek for 5 minutes.
Thank you. I will be sharing my time with Mr. Maloney. Thank you to both witnesses. You've made your positions extremely clear. Here in Canada, obviously, neither of you would ever be required in any way to participate in medical assistance in dying, should, in fact, it be approved at the end of the day for the sole purpose of a mental illness. However, having said that, and as I say, you've made your positions very clear, can you think, if that should occur, if it should become legal in Canada, can you think of any safeguards, some particularly stringent positions that you would want to see before MAID was applied and accepted for patients? Can either of you think of any?
Did you want me to begin?
Yes, sure, Doctor.
Although we could sit here and say, well, maybe, there's a certain amount of time that one will have had to live with a critical illness before they're eligible. Maybe there's a certain number of treatments that they will have to have received before they're eligible. The fact is that none of those have been proposed. There's been great opportunity to say, okay, we need to make sure that the bar is very high, and nobody has stipulated anything about trying to define, well, how high should the bar be? And in spite of how high the bar is placed, there are two things that we can't resolve. We don't have a crystal ball. So even somebody, and the patient I described, this is after years, we can't predict who will get better. And we know that over time, the vast majority do improve. And finally, we cannot distinguish MAID from suicidality in patients with chronic mental illness who have chronic suicidality.
Would you have any possibility of suggesting some safeguards should this be allowed? Dr. Gagnon, in fact, gave us some in the previous panel, but would you think that there could be some conditions that could be applied?
Well, I think if we want to be serious about trying to meet the needs of patients with mental health issues, then we need to think about the totality of their suffering. For us to talk about MAID as
Dr. Gagnon?
Dr. Gagnon?
Yeah, no, je pense que c'est...
It's like what Dr. Chochinov was saying. The problem lies within the fundamental difference between physical illness and psychiatric illness. Wanting to die and feeling suicidal is part of psychiatric illness. It isn't really possible to differentiate between an authentic MAID request and suicidality that can get better. I'd like to, or rather, when it comes to guidelines that should reassure us, and this is very tragic, I'm not sure what to answer.
Seconds.
Right, okay, thanks. Either of you doctors, would you agree with me that the guardrails that would be put in place should be applied equally and consistently from city to city within a province? Either one, yeah, Dr. Gagnon.
Dr. Chochinov?
Or Chochinov, either one.
They should, yeah.
Okay.
Okay.
Yes.
Yeah.
Okay. Now, if
Yes.
you've got province to province, does your concern increase?
Yes.
Okay. Are you concerned that there's people are going to be doctor shopping, or in the case of going from one province to another province, forum shopping to get the answer that they want to receive?
Yes, yes.
Are those, in both of your opinions, good reasons not to proceed with the expansion of MAID for mental health as a sole underlying medical condition?
Well, that's part of the reason.
Some of many.
Yeah.
Okay.
Yeah.
All right. I think I'm pretty much out of time. I'll stop there. Thank you.
Thank you very much. And we will now have Monsieur Thériault. You have 5 minutes.
Oui, merci.
Well, thank you.
Dr. Gagnon,
Dr. Gagnon, I imagine that you're aware of the expert report that was tabled and which was used by the committee in the last parliament, which was shared by Dr. Gupta. I suppose you're comfortable, well, you're aware of the recommendations of this report. In that report, in those recommendations, were there not some safeguards, precautionary principles that would help or is enough? What I'm saying is that if psychiatry cannot predict a person getting better or not, and for years, decades, a person suffers, what about the decision-making of such a person? Sometimes we say MAID should never be applied or suggested when there is a suicidability. Often there are some vulnerabilities and people don't feel comfortable. There are some nuances to be made. Does that report take into account your concerns? In Quebec, they decided not to go ahead with it, but the report had not been tabled yet when Quebec made that decision. Given the content of this report, don't you think it would be possible that this report reflects your opinion, or are you totally against any form of MAID? Once more, here we're talking about psychiatric problems. So that's the difference between physical illness and psychiatric illness. Even if we seem to have common points between those two, but some patients, some people are not in a crisis statement, but they have this illness that does impact on their judgment. Sometimes they do heal. I said it in my document. Well, we haven't yet read your memoir, your brief. It's a lady who wants to die, has been wanting to die for decades, and suddenly something happens in her life. For 20 years, she said she wanted to die, and then suddenly there's a change of state. People are not necessarily in crisis when they want to die. Those criteria are there, but they don't go far enough to justify psychiatric assessment. But if we refuse this, won't there be a certain number of people, a small percentage? I'm sure that some of your patients might have committed suicide at some point. We're talking about end-of-life care forever. That is trying to use a treatment or another to alleviate suffering, but we can never heal these people, and they will eternally suffer during their life. Don't you have these kinds of cases in psychiatric medicine? Dr. Chochinov was talking about medication, but there are other human intervention. In face of sufferance, there is techniques, treatments, electroshocks, electromagnetic stimulation, relationship, psychotherapy. art therapy. We don't offer all these to our patients. When we work in end-of-life cases, we can see what happens with someone who's poor or not. When a person is at the end of life, we support them. What about musicology to help someone who suffers? Art therapy also. There are so many things to do. On top of chemical treatments, psychotherapy, there is a need for more psychotherapy.
I'll move to questions from senators.
Senator Delphine, I think this time I'll try to keep people to 2 minutes because we're trying to get out. There's absolute cutoff at 9:45.
Thank you. So there are two things you're saying is that first there is the irremediability of the illness. You said that's difficult to predict who is in this irremediable situation and who is not or won't be at one point. And the second point, if I understand well, is the particular nature of the therapeutic relationship between the patient and the provider, the psychiatrist here, which is different from the normal medicine to an extent. Could you expand on that? Or am I wrong to understand that's what you're saying?
Sorry, Senator, you will have 3 minutes in total.
Well, I mean, I think I began by saying that the two significant problems, the problems that won't be resolved even if there's a further delay, is we can't predict who will get better and who won't get better. The other thing that I said is that we can't distinguish between suicidality in the context of chronic mental illness and bona fide requests for MAID. From there, and I think you're asking about me to say a little bit more about the therapeutic relationship. And we know when we look at the efficacy of any psychological intervention, it comes down to the therapeutic alliance. The strength of that alliance is the thing that seems to be most helpful in predicting a successful outcome. So, I mean, oftentimes, though, people forget about that, and we hear people saying, there's nothing more we can do. These words should be expunged from the repertoire of anyone doing medicine with chronically ill patients, because what we can always do is we can show up. We can be present, we can be attentive. And you might say, well, you know, that sounds very lame. You know, that doesn't sound very profound. Again, there are studies that show in the absence of showing up, the rate of suicidality increases.
The resources to provide that?
I'm sorry?
Isn't there a shortage of resources to provide that? That psychiatry, we are a shortage of psychiatric?
Well, I mean, I think you're asking, can we afford to do this? And I guess I would flip it on its head and say, can we afford not to do this? I mean, if we don't do this, then what are we left with? We're left with people who feel abandoned, who feel alone, who feel that no one cares. And those are the things that lead to hopelessness. And our studies show that hopelessness is the most ardent predictor of suicide outcome.
I've noticed. Thank you. Thank you.
So thank you, Senator Delphine. Senator Martin, 3 minutes.
Yes, my question is for Dr. Chochinov. And you mentioned in your response to Senator Delphine about the therapeutic relationship that you have with your patients, and that is the foundation of the importance of that, and that it's built on clear commitment that the clinician believes the patient's life has value and is worth fighting for. So I'm just trying to imagine psychiatrists and like medical professionals having to offer MAID or talk about MAID, like what it does to that relationship. So I think you've already given us some examples, and that, you know, we should just expunge just saying, you know, it's not going, there's nothing else we can do. But how important is that relationship? And then when you talk about MAID as an option, like what it does to the profession itself? Well,
again, as I said, I mean, this fundamental commitments to continuing to be involved is vital. And if you remove that guardrail, then, as I said in my statement, you change the therapeutic chemistry. And that's not just something that 200 or so or 500 or so psychiatrists who are willing to say, you know what, I'm prepared to step up, need to be comfortable with. There are tens of thousands of mental health care providers out there who, I have people who have spoken to me saying, they are frightened that the minute those guardrails are lifted, patients that they've worked with for years or for decades are simply going to choose MAID. The other thing I thought you were going to ask is, well, what happens if we are obliged to ask for MAID? And, asking someone if they would have considered MAID, I would point out, isn't a benign communication. It's like discovering that hemlock is being placed on a menu in what you thought was your friendly family restaurant. No one is saying that you have to order it. No one's saying it should rank amongst your top choices, but you are being told that the servers are prepared to bring you hemlock, that they have made peace with the possibility that you might select it, and that the choice is entirely yours. So being forced to broach the option of MAID for mental illness really affirms patients' deepest anguish that perhaps their lives really are worthless, that their lives are devoid of meaning, and that being served up death is an appropriate option.
Well, I think there's nothing more for me to add other than to say how ironic it seemed that this is what we're talking about, that psychiatrists are having to or choosing to talk about MAID as a potential option, that this is something that would be happening. So to me, it seems like one of the most impossible situations for the profession itself. But I've run out of time, so I will move to the next.
Thank you. Senator Moody for 3 minutes.
Thank you, Mr. Chair. Dr. Gagnon, I believe I've heard you express the opinion that it is impossible for psychiatrists to say if someone with a mental disorder has a grievous or irremediable medical condition, or that in fact they're not suicidal. However, the Canadian Psychiatric Association has developed guidance on how to assess such matters, and the AMPQ also holds the view that such assessments are possible, suggesting that this impossibility that you have expressed does not in fact reflect the state of knowledge in psychiatry. Would you comment on that?
Yes, these reports, ces rapports.
These reports, these documents stem out of consensus amongst a couple of psychiatric doctors or some psychiatrists who are interested by the topic. And we talked to our colleagues. The first briefs that were sent, well, it was easy to find other colleagues who were in agreement, director of departments or others, who were saying it was not possible. So the question is still being debated. Some psychiatrists say we can, others say no.
Asked a patient in your care if they have considered suicide. We call it suicidal ideation. Have you ever
Have I asked patients if they consider suicide?
Yes.
Absolutely.
So in your experience, did that lead to an attempt of suicide? Or for that particular patient to want to commit suicide? You made an association between a discussion about MAID leading to the person wanting.
Yes, but you're making the mistake of thinking that my asking about suicide.
I'm asking a question.
And I'm attempting to respond.
Sure.
What you're saying is that in asking about suicide, I am giving a person an opportunity to share their thoughts. In asking if somebody has considered MAID, I am saying to them, this is a possibility. This is an option that you might consider.
Sure, I agree
There's
with you.
a vast difference between those two.
I'm not sure I agree with you. I think there is quite an association between suggesting to a patient that they may be considering suicide based on your assessment of them and where you think they're at. And MAID is no different. MAID is a therapeutic option that is being offered to individuals who are deemed to be at that place in their therapy, in their clinical situation, when they may not have
your time is up, Dr. Chochinov. You want to offer a very brief response to that?
Yes. When you ask somebody about suicide, you're giving them an opportunity to share their thoughts about self-harm. When you're asking them if they've considered an option of MAID, you're saying something about your willingness to consider that as an option that you will give to them, not something that they will do to themselves.
Thank you. Senator Wallen for 3 minutes.
Thank you. To Dr. Chochinov, are you opposed to MAID in all circumstances, even with irremediable physical conditions?
You know what? I like to follow the evidence. I think I have an ambivalent relationship with MAID. I mean, what I see happening in palliative care does concern me, because there are many instances where instead of responding to what's causing somebody's suffering, people get into a very legalistic stance and say, do they meet criteria?
Yeah, I mean, so there are situations in which you'd consider that if somebody was had an irremediable fourth-stage cancer.
Yeah. No, my opposition to MAID for mental illness is based on the data.
Yeah, no, okay, I was about something else, but I'll just move on, because the Supreme Court ruled on this matter in 2016 and again in 2 subsequent decisions, and really laid it out in its simplest form as saying this should be a question of choice, a matter that a doctor should and a patient should have a discussion, and families should be included in all of that. Nobody is forcing this. It's not mandatory in any way. Yet you've suggested that you feel very comfortable usurping a patient's right to choose an end-of-life option. You discuss this as something you've written about intensive caring, which you would be comfortable imposing your view and your intention that they should carry on at all costs, regardless of their own views and their own willingness to choose a different option.
Well, look, we're talking about MAID for mental illness, so let's be clear with what this topic is about. Patients who are mentally ill have self-loathing, chronic suicidality, and feel that their lives are worthless. We have to be mindful of that and understand that expressions of suicidality in context of somebody who has a chronic mental illness can't be distinguished from a bona fide request for MAID.
No, but you're saying that all questions of people with all forms of mental illness, if they begin to discuss or want to choose the option of MAID, you're saying that's instantly a question of suicidality. I don't think there's evidence to that.
Well, I happen to have the document that was created from the Canadian Guidance on Medical Assistance in Dying. And if you give me a moment, you have to give me 2 moments. I thought I had it all here.
I think if we could just carry on with the discussion here, which is you seem comfortable with...
We're out of time, Senator Wallen. We go on now to the last, Senator Wells, for 3 minutes.
Thank you. Dr. Gagnon, do you practice in the field of MAID actively?
No, I'm a psychiatrist.
Okay. So you don't make any assessments. You haven't gone through any training.
No.
Same question to Dr. Chochinov.
I have seen patients who have requested MAID who've been referred to me for dignity therapy. That is the extent that I've been involved with.
You haven't gone through
MAID.
any specialized training, any of the clinical guidance?
Well, I went through 4 years of postgraduate training as a psychiatrist.
But
I would say that
not the current practice and that's been established, or the current training.
No, but I have read the guidelines.
Okay, but you haven't gone through all the hours of the workshops. Is that correct? Neither of you?
No, just 4 years of
Okay.
psychiatry
Great.
residency.
Thank you.
And post.
Thank you. So, you know, is it, Dr. Gagnon, is it possible to predict with certainty the future of all physical conditions?
No.
Okay. So, you know, from my perspective, we're seeing this false dichotomy start to happen between mental and physical illness. People with mental disorders make life and death decisions all the time in healthcare. So by this logic we're hearing today, they should be excluded from making life and death decisions about their health, refuse treatment for cancer, stop dialysis, request do not resuscitate orders. So it seems like a patient is never allowed, from the perspective we're hearing, that they've had enough treatment. There's always more treatment that they should be going through, that we're never going to give them a choice.
It's because c'est parce que c'est ce qu'on
Suicidal ideation is part of mental illness. This is not the case for physical illnesses. That's the difference.
Illness or mental disorder?
Non, mais quand un patient
No, but when a patient
quand on a un patient, si un patient
when it comes to a psychiatric patient that is suicidal and wants to die and is suffering of a major psychiatric illness, this is suicidal ideation. It's not authentic euthanasia wishes.
Speaking from your own perspective and experience, not from the Canadian Psychiatric Association.
Non, effectivement, non, c'est de...
Indeed. We are a group of psychiatrists who think differently.
It doesn't matter.
Inaudible.
The question all the time either.
Time?
You have no more time.
Okay, thank
I'm
you.
sorry.
Okay, we'll go to round two, and we have 3 minutes now for Mr. Lawton.
Thank you very much. My questions are going to be for you, Dr. Chochinov, and we only have a few moments, so if you could be as brief as possible, I would appreciate it. There are good doctors and bad doctors. There are doctors who go out of their way to keep current and others who don't. There are doctors who are more diligent than others. They're humans, and I understand this. Do you believe that there are doctors who are more philosophically or ideologically inclined to view MAID as not just something that should be available, but as something that is desirable for patients? I see you're muted.
Yes, I believe there are doctors who are philosophically bent in that direction. Yeah.
And what are the implications of that in a mental health context where you have patients who may be very impressionable or vulnerable or who may not know what their trajectory is or could be?
Well, I mean, first off, I mean, I'm suspect of doctors who, when they express their expertise, do so in the legal realm rather than the medical realm. So for a doctor to stand up and say, you know, this is about autonomy, this is about choice, say, well, let's talk about medicine. I mean, let's talk about the psychology of suffering. When somebody, and it's kind of ironic, when you have a provider who says, you know, I'm willing to provide MAID, sometimes initially what happens is the patient feels they're understood. It's kind of this collusion around a sense of hopelessness. I'm finally understood. Unfortunately, where that therapeutic relationship leads to, literally and figuratively, is a dead end. So the disposition of the doctor has a profound influence, which is one of my supervisors said, if two people are in a room, it's helpful if one isn't hopeless.
I speak from experience here as someone who's been very outspoken about my own struggles with mental illness, that it is a years-long battle for many people. And there are psychiatrists I know that have had therapeutic relationships with patients that have lasted decades, and improvements can be incremental over time. But there is something called compassion fatigue. And I'm wondering if you could just, in the 30 seconds I have left here, speak to how that could affect physicians and their patients in the context of MAID for mental illness.
Well, when you're dealing with somebody who has a chronic, serious mental illness, it is overwhelming. It's overwhelming to the person who's afflicted. It's overwhelming to their family, and it's overwhelming to the healthcare provider. Hopelessness is contagious, and when people start to feel hopeless, they begin to look for solutions. And MAID, when it arises, appears as if it's a solution. But as I say, it's a solution only in terms of it ends the life of the sufferer. So
Okay, thank
what
you,
happens
Doctor.
is, yeah.
Thank you very much. And we're going to now ask Ms. Tesser-Dirksen. Okay, so Ms. Lapointe.
Thank you. Dr. Gagnon, I'm going to build on the questions that were asked by my colleague, MP Jazik, when she asked about what safeguards and measures would need to be in place within the healthcare system to have MAID for mental illness be allowable. My question to both of you is, what metrics would you use to determine whether the healthcare system is ready for MAID for mental illness? What metrics would you use?
C'est difficile à imaginer présent.
It's hard to imagine this at this time because we haven't yet found a way to differentiate, and I will be repeating myself, but differentiate suicidal ideation from an authentic wish to die. Studies from Belgium or the Netherlands have already shown a broadening of the safeguards. All sorts of reasoning is emerging. For example, a pet has died or depression, and this worries me. It is hard to imagine that guidelines would exist and those same guidelines remain too vague.
Reference Belgium and Netherlands. So my question to you is, showing expansion beyond these rare cases, what concrete policy design do you think would prevent scope creep in Canada if MAID were ever extended to mental illness?
J'ai de la difficulté à voir qu'est-ce qui pourrait, pourquoi.
I struggle to say how we would possibly be superior to other countries that have already proceeded. Same thing for physical illnesses. I was in Quebec when MAID was only for end-of-life care, and use of euthanasia has now broadened for physical conditions. In countries where MAID for mental illnesses already exists, the scope is also broadening. Which policies would we need to prevent the examples that you described? I struggle to give you examples. Indeed, it is not possible to differentiate authentic suicidality from an honest wish to die. It's not possible to distinguish the two. Thank you. You're telling us that it is not institutionally possible to determine whether a patient requesting MAID is doing so for reasons other than mental health? You've never been asked to assess a patient's decisional capacity? Not with a psychiatric illness. Psychiatrists tell us that they do this all day for situations in which MAID is requested. You've never assessed a patient's decisional capacity. Inaudible. I've asked the question 3 times. You've already done this? Yes. Okay. Is it easy to establish that there is no suicidality linked to the person's condition? In most cases, it's doable. When it comes to mental illness and other mental issues, you believe that there are no directives and guidelines in the experts' reports. If the clinician realizes that there is a suicidality risk, despite the patient's willingness to do so, the clinician should be requiring treatments and suggesting other types of actions. Therefore, it's not because MAID has been requested that it's going to be granted. And it is that bridge that seems to be in question. In your perception, that slippery slope seems to be a fait accompli.
Senator Wallen for 2 minutes.
Thank you. I just want to make sure I've understood the exchange properly here, that we've agreed that suicidality is not present in every person who wants to choose MAID. Sorry,
I'm trying to imagine an
Dr.
instance
Gagnon,
where you...
go ahead, because he was just having this discussion.
Okay, sorry.
Suicidality of psychiatric patients, where suicidality is part of the illness.
No, what I'm asking, and I think we were discussing with Dr. Chochinov, that a person's request for MAID or a willingness to want to discuss it or have it presented as an option is not necessarily an indicator of suicidality. Would you agree with that, Dr. Gagnon?
No, you mean outside mental illness?
Well, either way. I mean, it's a more general statement.
Well, if there's mental illness, that's what you have to look at.
Okay, in mental illness, do you think anybody that wants to discuss other options or end of life or refusing treatment is expressing suicidality?
That's what, so far, I'm not able to differentiate what is suicidality or quote unquote real.
You're not able to discuss distinguish as a professional, or you mean the patient is, and I'm just not clear.
As a professional.
Okay, Senator Wells for 2 minutes.
Okay. Dr. Gagnon, I'm still a bit confused by what you've said. So I'll ask this question. Have you ever consulted on a patient with a mental disorder who wanted to make a life and death decision about their physical health, for example, refusing dialysis or cancer treatment?
Yeah, refusing, yeah.
Okay. So, in that case, were they all suicidal? Or in some cases where the patient was considered able to make their own decisions, capable of making their own decisions?
Some case they could, yeah, they were able to make. Yep.
Okay, you've answered my question. Thank you.
No. Senator, well, I don't know what to make of it now.
Yes. Okay, and with that, I'd like to, on behalf of the committee, thank our panelists for this final grouping, and thank you for your testimony and your time this evening. Thank you, colleagues. We have reached the end of this, more than 3 hours, but appreciate all the work that you are putting into this, and we are finished with this committee. So with that,